Well, welcome back. We've talked about patient noncompliance, physician noncompliance, drug interactions, office hypertension, stiff brachial artery. We've talked about cocaine, amphetamines. Let's now turn to this patient who has a previously undetected secondary form of hypertension, such as renal parenchymal disease. And a good one there might be polycystic kidney disease, because polycystic kidney disease may present with very high blood pressure in the setting of a normal serum creatinine and no proteinuria, whereas glomerular diseases like diabetic nephropathy or chronic membranous nephropathy or chronic lupus nephritis, any of the glomerular disease processes usually have proteinuria and then develop impaired renal function before they develop hypertension. Polycystic kidney disease is one that might have bad hypertension right from the beginning. But any of the chronic renal parenchymal diseases may be the reason for the hypertension. And as we've said, these patients may need furosemide in larger doses, and certainly get the dose of furosemide up there to 120, 160 milligrams a day if the creatinine clearance is less than 30 milliliters per minute, or if the serum creatinine is more than 2.5 to 3 milligrams per deciliter. I alluded to at the beginning renovascular hypertension, someone whose blood pressure has always been normal and now is suddenly out of control. Primary aldosteronism, which we used to say accounted for only about 0.3 to 0.5% of all hypertensive patients, we now pretty much agree that it may account for 3 to 5% of patients with hypertension. So primary aldo, and I'm going to talk about that because it's becoming more and more readily, easily recognized as a cause of secondary hypertension, pheochromocytoma, hypo and hyperthyroidism. This is a very important slide. If you don't remember anything about secondary causes of hypertension, just take this one to the bank. There's typical or garden variety, like I like to say, or essential hypertension. What might the features be of atypical hypertension or non-garden variety hypertension, making you think of a secondary cause? The age of onset of severe hypertension, here I'm defining that arbitrarily as more than 180 over 110 in someone very young or much older. I would probably change this now because I'm getting older to more than 60 years of age, but then the literature, the classic teaching is under 20 or more than 50. Severe hypertension, target organ damage, grade 2 or worse optic fundi, a serum creatinine more than 1.5 milligrams per deciliter, cardiomegaly or LVH. Evidence of target organ damage might make you think of a bad secondary form of hypertension causing bad hypertension. And this is really very simple. Features suggesting a specific secondary cause of hypertension. Unprovoked hypokalemia. By that I mean you see a patient in your office with potassium of 3.2, not taking a diuretic. Right away the red flag should go up that they might have primary aldosteronism. Now you might have unprovoked hypokalemia from renal artery stenosis, which is activating the renin-angiotensin-aldosterone system and causing secondary hypertension. And on a statistical basis in an elderly person with generalized vascular disease, that's probably more common than primary aldo. But I would think of those two conditions, secondary aldosteronism from renovascular hypertension or primary aldo from unprovoked hypokalemia. An abdominal bruit in the belly, particularly if you hear a diastolic bruit in the belly of a young Caucasian woman. That should make you think of fibrous renal artery disease. Variable blood pressure with tachycardia, sweating, tremor, and pallor, not flushing, pallor, should make you think of a pheochromocytoma. And a family history of kidney disease might make you think of polycystic kidney disease. Proteinuria makes you think of chronic glomerular disease. And if you have diabetes with proteinuria and a creatinine of 2, that makes you think of diabetic nephropathy. Very difficult to control the blood pressure in overt diabetic nephropathy. And then, of course, a poor response to an appropriate drug regimen makes you think that something else is driving the blood pressure, like in renovascular hypertension, marked activation of the renin-angiotensin system, Or in pheochromocytoma, you have the patient on a good regimen and you can't control the blood pressure. The catecholamines are driving the high blood pressure. So here's an example of a patient with high-grade bilateral renal artery stenosis. You see the narrowing right at the takeoff of both renal arteries from the abdominal aorta. And some of the clinical clues to renovascular hypertension would be the onset of severe hypertension under the age of 30 or over the age of 50 to 55, accelerated or malignant hypertension, unexplained deterioration of kidney function during therapy with an ACE inhibitor or an angiotensin receptor blocker, acquired resistance to a previously effective antihypertensive regimen, which we've mentioned several times as a clue, and a diastolic abdominal bruit, as I just mentioned, would make you think of fibrous renal artery disease as opposed to atherosclerotic renal artery disease in a young Caucasian woman. What about primary aldosteronism? Persistent hypokalemia during diuretic therapy despite concomitant administration of potassium-sparing agents and or oral KCl. So let's talk about the serum potassium for a minute. We already mentioned unprovoked hypokalemia, someone that's not on a diuretic. But let's say you have somebody on 12.5 milligrams of chlorothalidone once a day, or hydrochlorothiazide 12.5 milligrams twice a day, which would be reasonable dosages of those two diuretics. And someone comes in with potassium of 2.7. And you say, oh, well, it's due to the diuretic. Well, it's probably not due to the diuretic, because it turns out that only 7 to 8% of patients on those kinds of doses of diuretics drop their potassium to less than 3. So a serum potassium of less than 3 on reasonable doses of diuretics should make you think of primary aldosteronism, unless the patient is eating too much salt, or unless the patient is potassium starved. So why too much salt? Because if a patient's on a thiazide diuretic and is eating a lot of salt, they're delivering a lot of salt to the distal nephron, to the aldosterone site, and the thiazide diuretic is blocking sodium reabsorption before the aldosterone site. So you have a whole lot of sodium being delivered to the aldosterone site, and then that exacerbates sodium-potassium exchange, and you may get a serum potassium of less than 3. Now, I remember once I was giving this discussion at a major medical center in Dallas, and someone said, you know, Dr. Pohl, you see all those patients at the Cleveland Clinic who can afford fruits and vegetables. But down here, we have a lot of indigent patients, and they are potassium starved because they can't afford fruits and vegetables and foods that contain potassium. And they're only eating 20, 30, 40 milliequivalents of potassium a day. Plus, they eat a lot of salty foods, and they're on a thiazide diuretic, and we see thiazide-induced hypokalemia to 2.7 all the time in people that are in low-income populations that eat too much salt and not enough potassium-containing foods. So, this little clue about a potassium of less than 3 in a patient on a thiazide diuretic is a pretty good clue to primary aldosteronism, assuming the patient is not potassium deprived and assuming that the patient is not ingesting tremendous amounts of salt. And by the way, you can check for both of those by the 24-hour urine collection, because you can order the 24-hour urine sodium, and that'll tell you if there's potassium excess in their diet, and just add a potassium to it. Because if the urinary potassium is only 20 or 30 milliequivalents per liter, that's all they're eating. And then that's how you know your patient is potassium starved. Resistance to antihypertensive therapy and obstructive sleep apnea, particularly in obese patients and the African American population, has been described extensively by David Calhoun from the University of Alabama, and obstructive sleep apnea is becoming another clue to primary aldosteronism. And so is the elevated renin to aldosterone ratio, which you see here. So the group in Australia and Brisbane a number of years ago popularized this concept of the plasma aldosterone to plasma renin activity ratio. And these are simple blood tests. We get them back the next day. If I order them today in the office, I'll have these results tomorrow. And so they said that the plasma aldo to plasma renin ratio of more than 30 is a very good clue to primary aldosteronism. And we've already talked about spontaneous hypokalemia, or a serum potassium of less than 3 on conventional diuretic dosages. Remember, if you have spontaneous hypokalemia, by that I mean the patient is not taking a diuretic, and you see a serum potassium of 3.1 or 3.2, the next thing I would do is I'd get a plasma aldo to plasma renin activity, and the ratio is 40. Now you have 2 good clues to the diagnosis, and get a 24-hour urine collection, and if the urinary potassium is more than 30 to 40 in someone that has a low serum potassium, that means there's urinary potassium wasting. That's another clue to primary aldosteronism. And then you refer the patient out to an endocrinologist or a nephrologist, and you look for an adrenal adenoma, or at least you hope you find an adrenal adenoma, and you hope that it's functional, and then you remove it and you cure the hypertension. And this is a diagnosis that is fun to make, and it's easily made by the family practitioner with these clinical clues. Pheochromocytoma, you all know about these clues, these symptomatic paroxysms of tachycardia, palpitations, tremor, sweating, blanching, not flushing, labile hypertension, substandard weight. The board exam question clue always is a pressor response to antihypertensive drugs during the induction of anesthesia. So you have a 45-year-old man that's coming in for a back operation, and during anesthesia has a tremendous spike in the blood pressure. That's your clue to pheochromocytoma. Occasional occurrence with neurocutaneous syndromes, unusual lability of blood pressure, orthostatic hypertension, and abnormal glucose tolerance. And the big advance in pheochromocytoma today is the tremendously high sensitivity, 97 to 98% of plasma metanephrines. That's the gold standard for screening for pheochromocytoma. You get that result back the next day. In the old days, we used to have to order 24-hour urines for metanephrines, VMA, catecholamines. We still do that. 24-hour metanephrines are very good. They're almost 100% specific. 24-hour catecholamines are very good, almost 100% specific. But the sensitivity in your office practice of screening for pheochromocytoma is an elevated plasma metanephrine level, and if the plasma metanephrine normal is normal, they do not have it, you're done. And then those symptoms are probably due to hyperthyroidism or an anxiety tension state, or maybe some drug that the patient is taking, or maybe some amphetamine that you didn't know about. Clinical clues to renal parenchymal disease, we've alluded to some of them: proteinuria, renal insufficiency, hematuria. We talked about polycystic kidney disease in elderly patients that have protein in the urine and the dipstick is negative. You might check the urine, particularly if they're anemic and have a high SED rate and you think of multiple myeloma. You might check for urine protein by sulfosalicylic acid. The random or spot urine protein to creatinine ratio and 24-hour urine collections tell you about the amount of proteinuria, and a renal ultrasound tells you whether or not they have polycystic kidney disease. Hyperthyroidism is associated with a hyperdynamic circulation characterized mainly by a high systolic blood pressure. Hypothyroidism is characterized by a high prevalence of diastolic hypertension with the usual associated findings of fatigue and constipation. Hyperparathyroidism by itself is not a frequent cause of hypertension. Additional causes include increasing obesity. Sleep apnea is widely associated with hypertension. It turns out, however, in controlled trials that although sleep apnea may not be good for your oxygenation and may make you tired in the morning, and it may cause high blood pressure, that CPAP only reduces the pressure by a 2 to 3 millimeters of mercury in the studies that have been done. Binge alcohol we talked about, anxiety-induced hyperventilation or panic attacks we talked about. Chronic pain is a big one. You see the patient in your office that's in a wheelchair or using a cane. They have chronic back pain. They have shoulder pain. Not only are they taking NSAIDs, but if you ask, I've learned this, it's taken me a long time to learn this, to ask the patient that I'm seeing with hypertension, is your arthritis bothering you today, Mrs. Smith? Is your back hurting you? That's killing me. My back is killing me. You're taking the blood pressure in the office, even with that oscillometric automated device. If they're having pain in the office, that's driving up their blood pressure. Sometimes organic brain syndrome causes refractory hypertension. So what have we done? We've looked at patient noncompliance or patient resistance. We've looked at physician resistance in all these things. We've looked at drug causes and drug interactions. We've looked at too much salt. We've looked at the stiff brachial artery. We've looked at white coat or office hypertension. We've looked at some of the common causes of secondary hypertension. And now we're down to that 2 or 3% with true drug-resistant hypertension. You've gone through all of the above. That's when maybe you want to send the patient to a hypertension specialist to figure out what might be the neurohumoral mechanism that is driving the blood pressure. We at the Cleveland Clinic have long been interested in neurohumoral aberrations responsible for refractory hypertension. So measure the renin. It may be up. You know, the renin is up in patients that are on ACE inhibitors from the negative feedback loop and ARBs, but maybe it's really up more and more and more than you think it is. Maybe they need a bigger dose of an ARB or an ARB. Maybe they need to be beta blocked as well. Maybe they need the direct renin inhibitor. The renin activity system may be markedly elevated. Aldosterone production might be up. That might be the time to maybe add spironolactone. You know, the old timers that are listening to this use spironolactone. When I was a medical student, everybody used spironolactone, aldactone, aldactazide were very popular drugs. Then they went out of favor because of some of the side effects, particularly breast soreness. Aldactone is making a tremendous comeback. The addition of aldactone to a patient with primary hypertension, whether they're in that 2 or 3 or 4% that have primary aldosteronism or not, is very effective in controlling refractory hypertension. If you're worried about the breast tenderness, try eplerenone. You might measure the plasma catecholamines. In these people with difficult hypertension, it's often 700-800, which is abnormal, but it's not in the pheochromocytoma range. So add something that's a sympathetic inhibitor, like clonidine or prazosin. We often measure plasma volume here in this 2 or 3%, because even though the patient's on a diuretic, they may be retaining more salt and water than can be appreciated. They may be on a low salt diet. They may be on a diuretic. They may be on Lasix 40 milligrams twice a day, but maybe that is not enough. So measure the plasma volume. If it is elevated, then they need more diuretic. Maybe they need a thiazide diuretic and a loop diuretic, and maybe they need more intense sodium restriction. And we measure the peripheral resistance. And if the peripheral resistance is up, they need more vasodilatation, they need more ACE inhibition, they may need a calcium antagonist, and they may need minoxidil. Minoxidil is the one that you might have to go to if there's refractory hypertension with increased peripheral resistance. So in summary, what's our algorithm for the management of refractory or resistant hypertension? Is the patient compliant? If the answer is no, you stop there and you work on compliance. If the answer is yes, you go to the next step. Is the regimen adequate? All the things that we talked about. If the answer is no, you don't go any farther. You don't look for a pheochromocytoma. You don't look for primary aldo. If the regimen is inadequate, all the examples we discussed, you work on the regimen, keep bringing the patient back, be confident the patient's taking the pills. Then when the answer to that question is yes, and the blood pressure is still uncontrolled, you wonder about a specific drug or drug interactions. And if the answer to that question is no, then does the patient have pseudohypertension, stiff brachial artery? If the patient's younger, that's not the answer. Then it's probably office hypertension. So if the answer to the question, does the patient have office hypertension, is yes, then you focus on the reading you get from ambulatory blood pressure or from home blood pressure readings. If the answer to that question is no, then you go to the next step. Has secondary hypertension been excluded? If the answer is no, then you look for one of those secondary causes we discussed. If the answer is yes, then you have 2 choices. Then you can alter the regimen empirically, just fiddle around with the drugs that you've got, maybe add a second drug from the same category, and the blood pressure is controlled. Everybody's happy. If the blood pressure is not controlled, which is what I would do, evaluate some of these neurohumoral secondary pressor mechanisms and alter the regimen according to some of the guidelines that I just gave you a couple of slides ago. So target blood pressure is achievable, but often requires more than one drug. And these are some examples of the average number of antihypertensive agents needed per patient to achieve diastolic blood pressure goals in the UKPDS, in the ABCD trial, in the MDRG, in the HOT trial, where central hypertensive patients, about 30% had diabetes, by the way, and the African American study of kidney disease. And you can see these diastolic targets that were set up and the average number of blood pressures needed to achieve diastolic goals is anywhere from, to 3 to 3.5 drugs. But as you all know, it is always more difficult to achieve systolic blood pressure controls. In the studies of overt diabetic nephropathy in the Renal trial and in the IDNT trial, in only 40% of those 3,000 patients was the systolic blood pressure controlled to less than 140. Very difficult to achieve systolic blood pressure control. So what I've tried to do this morning with you is review in a very painstakingly, I hope, thorough fashion is a stepwise approach to these patients with difficult hypertension. Not mild hypertension, difficult hypertension, very common, and I hope this is useful to you in your clinical practice. Thanks very much for your attention.